review questions in during that time. Hi, everyone, and welcome to tonight's National Cardiology Board Review session. I'm Caitlin Grandstaff. I'm a third-year cardiology fellow at St. Luke's Mid-America Heart Institute, and it's truly a privilege to introduce, perfect timing because I can see your screen, Dr. O'Keefe. It's truly a privilege to introduce our speaker and my mentor, Dr. James O'Keefe. Dr. O'Keefe is the director of the Charles and Barbara Dubach Cardio Health and Wellness Center and the co-director of the Haverty Cardiometabolic Center of Excellence at St. Luke's. Those are the first of their kind in the country. He completed his fellowship at the Mayo Clinic and is board certified in cardiology, internal medicine, nuclear cardiology, and cardiac CT imaging. If that's not enough, he's authored over 475 scientific papers, cited more than 400,000 times, and consistently recognized as one of America's top doctors by his patients. He's also known to many of us through his best-selling books, his TED Talks with over 5 million views, and his passion for helping people live longer and better through lifestyle and prevention. For many years, cardiology fellows across the country have benefited from Dr. O'Keefe and his ECG website, which now has become a go-to resource for board prep. It started as a way to master ECG coding and now has expanded to include, we've got board-style clinical questions, echocardiograms, and angiograms, plus new features like topic filtering and interactive message boards. If you haven't checked out the new version of the website, it's definitely worth revisiting and you'll get a taste of it tonight. Tonight's session is meant to be high yield, interactive, and low stakes. So please, 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 the best version of this I can attest to as a fellow that he trains at Mid-America is to be interactive. So please unmute yourself and ask questions or share your thoughts as you ask questions. I'll also be moderating the chat. So if you're unable to mute yourself and want to throw an answer in, I will also communicate that for you. You can also drop comments or questions anytime, and we'll try to field those as we can. We'll try to keep this to about an hour. We apologize for running a little bit behind, but we'll give you really high yield content. And we know how stressful the lead up to boards can be. So take this as, a supportive space to learn, test your knowledge, get inspired by someone who's dedicated his career to teaching and improving cardiovascular care. And with that, please join me in welcoming Dr. James O'Keefe.
Great, Caitlin. I apologize profusely about the tech, like Caitlin and I went through this last night and spent a half an hour troubleshooting it. And then, I don't know, some glitches came up. I'm not a fan of Teams. It should be on Zoom. But anyway, glad you're all here. This is a personal, professional passion, making sure you guys pass the boards. And so, the stuff we're going over tonight, might have, as Caitlin says, is high yield. These are topics that have shown up on the boards recently. So, keep that in mind. And yeah, and we'd love it to be a discussion format. And, I love the new site because one of the great things is, there's a form under each case, and there's these forms are just blowing up, and it's more than I can deal with because it's a relatively we just launched it a couple of weeks ago, this new version. And so that being said, please give me feedback on that because it's really the great way to make sure this is well vetted, and to pick up, controversial things or outright errors. So this first case is a 50-year-old female with progressive shortness of breath and reduced stamina. And we have a few images here. Caitlin, do you want to comment on these images?
Yep, we're definitely seeing some RV enlargement there, I would say, just from the limited views and some tricuspid regurgitation.
Mm-hmm.
It looks like you're showing us something across the septum.
Mm-hmm.
I would think that that's an ASD of some sort. It's pretty large.
Mm-hmm.
Sort of a hybrid short axis view there.
Mm-hmm. So this, one of the reasons that you guys really need to, in my opinion, get on this site is because these are the board score sheets. This is the echo score sheet. There's 150 different boxes to check on here. And if the first time you ever see this is on the boards, it will definitely be an anxiety-producing kind of event. But there's So this is a secundum ASD with an enlarged right atrium. The tricuspid valve regurgitation is mild to moderate, and there's some RV volume overload. So yeah, there's a good view of it there, that secundum ASD with some mild TR there. You can see that as well. ASDs, both secundum and primum, as well as the other kinds, are sort of high yield for the test. So any questions on that one? All right. Okay, so this is a these are all real cases, by the way, here at Mid-America Heart Institute in Kansas City. This is a 35-year-old female smoker on oral contraceptive and ED with presyncope and dyspnea. Anybody want to take a crack at that? Either unmute or, send us a note in the chat box. Here's the score sheet. Again, this is like virtually identical to the score sheet on the ABIM CV board.
We've got some people in the chat who are jumping to kind of the final diagnosis. We've got concern for PE. We're seeing comments about right bundle branch block, sinus tachycardia, S1Q3, T3.
Perfect. Right. And the most common finding on an ECG and QPE, which probably will show up on your boards, is sinus tachycardia. And yeah, this is right bundle branch block. It's a complete right bundle branch block. It's important to know the RBB is, of course, 120 milliseconds or longer. So this is complete, not incomplete. It does have the S1, Q3, T3 phenomenon. And then these, so S up there, Q. The Q's are real small, but the T's are definitely abnormal. And lots of times you see these this RV strain pattern over here in the inferior or the precordial leads. And so it's hard to know what to score that. And we scored an ischemia on this. It's really RV strain more than ischemia. But there are PVCs here too. It's always important to scrutinize the rhythm strip at the bottom, because lots of times there is APCs or PVCs or, ventricular phasic sinus arrhythmia or something, but, strip across the bottom.
We have a question in the chat, Dr. O'Keefe, about just commenting, and you kind of alluded to this, but coding ST changes with RV strain. And I think that the big take-home message is
STT changes, there's really not anything like that. There's secondary to hypertrophy, and if there's RVH, that would be appropriate. I think we gave zero credit for the STT ischemia. It's like, if you want to score something, there's definitely abnormal. This is RV strain, so in the boards, you want to, the key is getting the big diagnosis here. It'd be acute chlorpulmonale, including acute pulmonary embolus. And, there's a sinus tachycardia and the right bundle, but like the scoring for that is, like the overwhelming thing is scoring for the QPE.
And we have a follow-up question about what about coding it as ST changes due to myocardial injury, specifically in the case of a PE, and when should we or should we not use that?
The only time we really recommend you use injury is if you see left bundle branch block with a STEMI, meeting Scarbosa, Smith modified Scarbosa criteria. Then it's very important. For an acute STEMI, it's kind of optional, because that it kind of goes along with ST segment elevation. I usually recommend that people do that. I was going to show you an example of that, but we'll get to it later. But yeah.
And then this is a great time to bring up, since we're talking about coding, do you mind just talking about your strategy about time management and focusing on sort of the high yield, higher points aspects of coding versus trying to get all of that nuance like the PVCs and PACs?
Yeah, I mean, you'll have about 2 to 3 minutes per case on day two. Day two is about the 2 hours is on ECG, and then the second 2 hour session is split about 2/3 echoes and 1/3 angiogram. So it kind of comes out to about 36 ECGs, and then maybe 12 or 13, 14 angiograms, and then 20 some 23, 24 echoes. So yeah, look for the major diagnoses, and be careful not to overcode. That's the general strategy. I'm going to show you some that are things you definitely should recognize. So this is a 84-year-old female with newly diagnosed cardiac amyloidosis and frequent PVCs. This is a good one to discuss coding nuance.
We've got some takers for AIVR, lots of takers for AIVR.
Very good. This is a classic AIVR. Lots of times it's only partly there, but like a ventricular rhythm that's above about 55 beats per minute, but below 100 beats per minute, at which point we call it VT. You can see the retrograde P wave here. The QRS duration is pretty long. So it's yeah, this is definitely and see, it's like you say, what's the axis here? Is this a right bundle? No. Once the rhythm is coming from the ventricle, you do not score the axis. You don't score any bundle branch block. You don't score, really Q waves or anything like that. This is a ventricular rhythm at about, 85 beats per minute with retrograde P wave, and it's AIVR. I think there were 2 of those on the last test. It's like AIVR is definitely something to bone up on. And lots of times you see, a few beats of AIVR. It's common in things like amyloidosis, but also post revascularization after an infarct. Or hypertrophic cardiomyopathy, dilated cardiomyopathy, hypokalemia, hypomagnesemia. It's not an uncommon thing. Even healthy, fit individuals can have it with high vagal tone. So
it looks like, we put all of our eggs in one basket and the only correct answer is AIVR. We have some questions about, should we be coding anything about the sinus rhythm or AV dissociation when we see this?
Yeah, that's a really good point. You should code AV dissociation when it's present, but that's a really good point, is that there's not AV dissociation because the P wave is retrograde, but it's in there pretty much, isn't it, the whole time, I think? Mm-hmm. Yeah, I think it's all the way through there. But that's when you see a ventricular rhythm, you think, code what the rhythm is, code what the atrial rhythm is, and if they're dissociated, you can cause AV dissociation and complete heart block. But yeah, it's a really important point. That's a whole sort of constellation of things you code when you see a ventricular rhythm. Look for the atrial rhythm and see if it's AV dissociation. Okay. Another one that you'll probably see. 56-year-old male runner, history of atypical chest pain. Any guesses?
We've got some benign early repull votes.
Yep.
In sinus rhythm.
Yep. Yeah. Sinus rhythm. And see this notching over here. That's kind of sort of classic for benign. And it's a runner. That's kind of the kind of person you see it in. And on this, there's like a normal variant ECG over here in the coding and the sinus rhythm. And then you want to code for over here, and the STT changes. There's early repolarization abnormalities, normal variant. That's another constellation that that will go together when you're coding these things.
They were on it. They had a normal variant in there too.
Mm-hmm. Yeah. So let's see, 1, 2. So the key is on the boards, you know, like the computer usually tells you what the rate is, but on the boards, you need to count the p waves. 1, 2, 3, 4, 5, 6, 7, 8, 9. You don't quite see the 10th one. So it's like 58. So this is sinus bradycardia, not sinus rhythm.
They also had that too. There's a question about, do you always double code for both early repol and normal variant when you see it?
Yeah. Mm-hmm. Yeah, because there's other types of normal variant. You know, there's other types of normal variant for sure that you can.
Would sinus arrhythmia be another normal variant? We're being asked in the chat.
Well, yeah, lots of times a normal variant will have sinus arrhythmia, but there's like this is what we just saw there. Juvenile T waves are inverted T waves in leads V1 to V3, usually in a woman less than 20 years of age. You know, so it's not always necessarily the benign early repol abnormalities that you're coding there. And, you know, I might say, like, we'll probably do more ECGs than anything else, you know, sadly, and maybe unfairly, but most people who flunk the boards flunk the ECG part of it. And there's really no reason you should do this. Like way back when I was at your guys' stage, like at Mayo in the 80s, you know, I could take the boards early before, you know, you had to retake the test, you know, so you get grandfathered in. So I did cardiology for 4 years, but I took it after 2 years, the test, and I knew that the ECG was overrepresented. So we kind of made this, you know, sort of guide, which became the complete guide to ECG, which has been like in 4 or 5 editions. But we incorporated all that into this. But that being said, even today, like the people who flunk the boards, lots of times they pass things else and end up, you know, flunking it because of their performance on ECG. And if you, I mean, honestly, there's like 400 and I don't know, 20 ECGs or something like that in here now. We've covered all the things that have shown up recently on boards, you know, extensively. So if you do a lot of these, I guarantee you, like you will do well on the ECG part of the boards. It's not that tricky. I mean, you just have to recognize these major diagnoses. Last year, there was quite a few, like a few anyway, pacemaker malfunctions. We'll go over a couple of those. So let's see.
We have a couple of quick questions, Dr. O'Keefe.
Okay.
One person's asking in terms of rate, I've been sticking to heart rate 60 and above as sinus rhythm, any less, such as even 59 or below is sinus brady. Sometimes the board's EKGs can make the rate very close to either. Do you think that that's a fair simplification?
Yeah. And you won't get, like, if it's 59 instead of 60, I mean, they're not going to they probably won't take anything off for recording a sinus rhythm versus a sinus bradycardia. That kind of falls into the category of like nitpicking. And so just count the P waves and do the math, you know, times 6, and you usually it's pretty straightforward.
And then do you use normal variant for sinus bradycardia?
You know, if it was by itself with an otherwise normal ECG, yeah, I would. But sinus bradycardia often is not necessarily a normal rhythm,
right.
You know, in some people. So this is a 55-year-old Vietnamese male with febrile illness and asymptomatic VT. This one shows up on the boards regularly. So you need to recognize this.
People are jumping on Brugada.
Right. This is a classic, you know, the florid Brugada. This is not an equivocal one. This and this is like, is this a right bundle branch block? Are these non-specific repolarization abnormalities? No, under clinical conditions, Brugada syndrome is the main thing to code here, and the sinus rhythm, you know. But it's yeah, this is something that you'll see on there. So sinus rhythm. So the right bundle branch incomplete and non-specific STT abnormalities, like you get neutral score for it. If people code those, I didn't take anything off for it. But for the board purposes, you code the sinus rhythm, the Brugada syndrome, and you'll get it. This is classic type 1. Yeah, last year they did code for the specific gene for Brugada 2. Was that SCN5? So yeah, make sure that you understand that. That
We have a
showed up.
question about, we've now had a couple of questions about coding low voltage in the precordial leads. Do you think we're meeting criteria there, and is it worth coding?
That's a really good point. It's pretty darn close. Like right here, I mean, this is like right on the edge, because that's one below, and this is like, yeah, I mean, you could code low voltage in the
Probably
line.
neutral.
Yeah, it's probably neutral, but that would be one of those, borderline ones. So I'll make a note and we'll put that in there to say that that's at least wouldn't get marked off for it. That's why I love having you guys look at this stuff.
Oh, we have some very nuanced questions just while you're picking on another one. If we have electrical alternans, if voltage alternates between less than 5 and greater than 5, which do you pick for voltage?
Oh, I mean, you take the
Probably just leave it.
You definitely take the largest, the largest one, which out of all of them, the largest one. So, yeah.
And then what about coding voltage in paced rhythms?
Yeah, you can do it if it's like we had a case recently that showed that you had amyloidosis and had a paced rhythm, and in the precordial leads it was less than 10, and so you definitely code that. Just you look at the not the R wave or the S wave, but the total excursion of the QRS is what you code for. Yeah. All right, so this is a 37-year-old female with no CV risks, hypertension, presents with chest pain and non-STEMI. I mean, like, her troponin was not subtle. It was like 1100 or something like that.
We've got SCAD, FMD.
Yep. There's not a code for FMD on the angiogram, but so if you look over, this is the score sheet for and this is the same, pretty much the same as the ABIM with subtle changes to avoid copyright lawsuits. But so there's a where is it? The coronary dissection. There it is. Coronary dissection, and that's in the circumflex. It was like an obtuse marginal branch, So, yeah, that is a classic finding. And lots of times SCAD can be quite subtle. And so, you like, this is a 37-year-old female that comes in and she's got STT changes, and then and the troponin bumps really high. And so sometimes you have to really scrutinize the angiogram to find the SCAD. In fact, that's often the case. We've had some really catastrophic SCADs recently that were hard to see. But so yeah, it's left circumflex, severe stenosis, and dissection. So you would code the severe stenosis. Somebody asked in the codes, so does a stenosis only apply to a fixed stenosis, like on the score sheet? Then no, that's not the case. It's like so it's a severe stenosis in the circ, and then you have to look at dissection, because it could be thrombus. There's coronary thrombus that you can code, or dissection. So if it's occluded or severe stenosis, you still have to code all of those.
We've had a couple of questions about if they can give you ventriculograms or aortograms on the boards. I
They
suspect
should.
probably yes.
Yeah, they sure can. Last year there was one. There was a question about an aortic aneurysm, but I think it was on the echo. It's an aortic in the setting of Marfan's. So here's
And
another classic answer that
presumably
has shown up on the boards too.
Presumably, since they don't give you aortograms or ventriculograms in the score sheet, that probably would be a day one topic.
Yeah, exactly. Right. Good point. Yeah.
All right, we've got a vote for myocardial bridge, severe LAD stenosis.
So this is kind of an exception to what we were just talking about, where like you could say, I don't know, there's a temporary stenosis during systole, but you wouldn't code this as stenosis. I mean, it's really classic. That's where the bridge often happens in the mid-LAD, and you see how it just kind of gets milled, kind of definitely squeezed down during systole. So yeah, this is again, this is the only thing to code here is myocardial bridging the LAD. Pretty straightforward. And strangely, that does show up on the boards. Yeah. It's a congenital coronary anomaly where the coronary part of the coronary artery dips into the myocardium, and so it gets squeezed during systole. Sometimes it can be associated with symptoms, but lots of times it's just not.
And Dr. O'Keefe, we've had a lot of
Usually
questions.
Usually it's not symptomatic. In fact, most of the time, if they have that, if they come in with atypical chest pain, I mean, it's not something we never intervene on that. Sometimes you might use a coronary vasodilator, but generally it's nothing to treat. Just reassure.
Are we supposed to be coding normal coronaries?
Well, I mean, if there's nothing else on there, then you'd code normal coronaries. There hasn't been one of those lately, but yeah, if, we do have an example of that in the TED, and this was quite controversial. There was something like this recently on the boards. A 19-year-old male student at the University of Minnesota fell through the ice while walking over a partially frozen river, rescued, resuscitated from VT on the site. In the ED, he was unconscious and ECG was obtained. What's the likely diagnosis here? Brugada, hyperkalemia, non-ischemic cardiomyopathy, hypothermia.
We've got some long QT, some hypothermia, some Brugada versus hypothermia, Osborne hypothermia, lots of hypothermia.
Yeah. So this does look kind of like Brugada. But the point is, do not be fooled by that. Like, the stem, it's like this guy was rescued from a frozen river in Minnesota in the winter, and hypothermia causes things like, if this is, you're scoring the CG, this is atrial flutter. Atrial fib flutter is very common in hypothermia, bradycardia, prolonged QRS. And this J wave here, it's called the Osborne wave. You can also see that in hypercalcemia, and of course normal variant like we saw before. But the thing in hypothermia, this guy was very hypothermic. The size, the magnitude of the Osborne wave is indirectly proportional to the temperature. So the lower the temperature, the bigger the Osborne wave is. And this guy was very hypothermic. He did survive, but his temperature was very low. So things like AFib flutter, prolonged QT, somebody mentioned, progressive widening, the QRS, ventricular ectopy. So Brugada can cause syncope and also has things like Osborne waves, but the stem really tells you what's going on here. So you would not code Brugada for this.
People are asking about if they're unsure about the diagnosis, such as AFib flutter on the score sheet. Would a reasonable strategy be to score both and risk, guaranteeing 1 point lost, or would you put all your money down on one?
You can do, lots of times it is AFib flutter. If you see, definite flutter waves in one section and fib in the other, you could score both of them. And this one, it's hard to know on this one. It does kind of seem to go from fib, from from flutter to it's looking a little more like fib here, but the QRS is pretty regular, so this is probably a junctional escape or something that's not really being, or maybe complete heart block. But yeah, most of the time, if it's fib flutter, we tell people to code atrial fibrillation. AFib flutter, when they show you examples of that, it'll be, very distinct flutter waves all the way through. And there was one like that on a recent test, just atrial flutter with, maybe right bundle branch block and left anterior fascicular block. That's that.
We do have lots of questions about fascicular blocks, if you want to take a moment on that, or if you have an example. Any tips to sort of tease out anterior versus posterior fascicular block, especially when it's paired with, a right bundle branch block or that sort of thing?
Yeah, you want to code both of them, so the this is an example of a normal variant, the sinus arrhythmia, 16-year-old who's high vagal tone syncope with having her blood drawn, that'd be a sinus arrhythmia, normal variant kind of thing. But so if you look at, yeah, you just need to know these cold. You will see several of these various, left posterior fascicular block, where you have right axis deviation, and then you'll see a Q wave in means one in AVL, or you can have left anterior fascicular block. It's the opposite. You'll see, left axis deviation with small Q waves and leads one in AVL, and these things often go along with right bundle branch block. Of course, left bundle branch block is left anterior fascicular block and left bundle branch block. You don't code the axis on left bundle branch block generally. It's generally left axis. You probably get neutral credit for it if you see if you code the LA the left axis there.
And then can we code LVH when we're coding left anterior fascicular block?
Well, it can be a little tricky if the only place you see it is an AVL, LVH. So then you'd look for voltage criteria, otherwise the Cornell criteria, the Sokolov criteria. You'll definitely see some LVH, and you need to code for that. Let's show you an example here. So this is a 46-year-old male with Japanese ancestry complaining of exertional dyspnea and palpitations.
Apical HCM we're seeing.
Yeah, very good. This is apical HCM. Huge voltage in these, these inverted T waves. It can be Wellens waves in the setting of ischemia, and can be seen with CNS, like head bleed or head trauma, that kind of stuff. But in this case, where it's just exertional dyspnea and palpitations, yeah, this guy had apical HCM, and let me show you another one here that. You'll see an ECG for apical hypertrophic cardiomyopathy probably, and it'll be one of these two. So this is a trickier one. It's a 20-year-old male varsity athlete had syncope during a basketball game. And his echo showed, pretty substantial hypertrophic cardiomyopathy. And this down here, these are called septal Q waves, inferiorly and laterally. And it's kind of confusing because you think it's septum, the anteroseptum's over here, but it's the big septum has this, electrical forces going away from the inferior wall and the lateral wall because it's activating the septum. And so, and like about a third of the time with hypertrophic cardiomyopathy, you don't have LVH voltage. but these STT changes you see are compatible with STT changes of hypertrophy, and especially in one in AVL there. But yeah, this is hypertrophic cardiomyopathy, and then you also code for the STT changes of hypertrophy. And the thing is, like you say, isn't that an inferior infarct? These Q waves, they're called Dagger-like Q waves in HOCM. They're not 30 or 40 milliseconds. They're narrower than that, and that's it's not an infarct. And this is a 20-year-old athlete, with syncope. This is HOCM.
Someone astute in the chat said Dagger Q waves, right as you said it.
Very good.
Someone asked a tough question. If they didn't give syncope in the clinical story, can we still say HCM?
I mean, it's a good question, and I kind of wanted to show this just because of those Dagger-like, Q waves. When you see those, that should raise the specter of hypertrophic cardiomyopathy. And these STT wave changes are kind of strange for a 20-year-old, but athletes sometimes have that. But yeah, it's a fair question.
And then in terms of distinguishing between apical HCM and regular HCM, it's really those kind of deep inverted symmetric T waves, the Yamaguchi pattern, that makes us think apical, correct?
Exactly. Yep. So this one shows up also on the boards regularly. This is a 19-year-old female with shortness of breath, chronic shortness of breath.
We have a vote for dextrocardio.
Very good.
Pulmonary hypertension.
Yeah, this is. I mean, it does look kind of strange, with the, you could say it's RVH, but this the R wave that goes away, that disappears, and this right axis deviation. So you'd code right axis deviation. The thing that often masquerades as it, that often shows up as well, is the incorrect electrode placement, where you see upside down P, QRS, and T wave in these one in AVL, but you have normal R wave progression. So that's the typical. Whereas here's another dextrocardia example here, where there's upside down PR and QRS, but the R wave goes away. So it's really the precordial. Look at the precordium, and if the voltage goes away, because the ventricle is in the right chest. So when you put those chest leads across to the left, you see less and less voltage. So yeah, you probably will see a dextrocardia on the ECG during. This was a really strange one that was sort of showed up on the boards.
And things like P wave axis could help us differentiate dextrocardia from an old posterior infarct.
Yep, for sure. And the history. So this is a 58-year-old female in the emergency department with sudden onset right-sided weakness, slurred speech, mild dyslipidemia, but excellent health. Never had heart symptoms or palpitations. Vitals are stable. She's got right hemiparesis and right facial droop. Lab shows normal. The blood cultures are negative. Multiple blood cultures negative. ECG shows sinus rhythm with no atrial fibrillation. Non-contrast head CT shows an acute ischemic stroke with left middle cerebral artery territory. Carotid duplex MRI showed no atherosclerosis. Given the suspicion for cardioembolic stroke, TEE is performed, revealing a mobile mass attached to the aortic valve with a stalk measuring 9.9 millimeters.
I think the second you showed that picture, people jumped all over papillary fibroelastoma.
Yeah, this is a papillary fibroelastoma. And that, again, the clinical history, this can show up in the board. So what do you want to do with this? Heparinize, refer for surgery, broad spectrum antibiotics, repeat TE in 6 months, dual antiplatelet therapy.
We like surgery.
Yeah, because once you have had a stroke and you see this mobile, ominous-looking mass, surgery is the right answer from the guidelines. We too try to really go by the guidelines, and Dr. Talal Asif, who's been helping me for the last year, with this has really had a huge influence and really making sure that that our questions are sort of backed up by guidelines, and a lot of the more recent questions in the Q bank are taken from recent guidelines, which may or may not show up on ABIM, but certainly be helpful on the in training exam or at your cardiology fellowship. The angiograms, so this is a 77-year-old man with 2 hours of substernal chest pain, elevated troponin, abnormal ECG with dynamic ECG changes.
People are seeing thrombus in the circ.
Very good, yeah. Let's see. There's another shot of it. There's the other shot, yeah. So what about, do you think we should code anything in the LAD there? There's some 50 to 60% stenoses there, and so you'd score that as moderate. Yeah, there's a total occlusion of the circ. I mean, it's a obtuse marginal branch. It's not filled by collaterals, I don't think, but always look for collaterals because that's one of the things. And then the thrombus. Yeah, there's definitely thrombus present in that circ. That's what that staining is. And then we said moderate stenosis in the LAD. We should just get 1 point or 2 points for that. But the main thing is, recognizing the thrombus and the acute occlusion in the circumflex territory. So, questions on that?
People are asking about losing points if you code normal, but there's mild disease. Probably not the most fair thing to ask, right?
Yeah, it's hard to know. I mean, if there's some mild luminal irregularities, there's a code for insignificant stenosis and insignificant stenosis. And if it's there, you can score for it. You're not getting marked off if there's plaque there. I'm not sure how much credit you'd get. Yeah. Trying to show you just stuff that's recently shown up. So this is a 34-year-old pregnant female, 22 weeks pregnant, presents to the obstetric clinic. Expect a test on a question like this. For routine prenatal visit, blood pressure measured twice with proper technique after 20 minutes of rest averages 164 over 112. She feels well, denies headache, visual changes, chest pain, dyspnea, neurologic symptoms, and epigastric pain. Physical exams unremarkable, no signs of preeclampsia, such as proteinuria or urine, point of care testing, edema, or abnormal reflexes. Heart sounds are normal. There's no evidence of intrauterine growth retardation. According to 2025 ACC/AHA guidelines, which is the most appropriate next step in management? Start antihypertensive therapy within 30 to 60 minutes to reduce blood pressure to below 160 over 110. Wait to recheck blood pressure for the next prenatal visit. Initiate an ACE inhibitor. Use atenolol to target blood pressure below 120. Plan immediate delivery.
But like A.
It's definitely
some votes
A.
for D.
No. Atenolol, if you can use a beta blocker in pregnancy, it would be metoprolol generally. And the ones that they'll usually ask you about, and they will probably ask you about treating blood pressure in a pregnant mom with hypertension, is labetalol and nifedipine are by far head and shoulders first line. Methyl-dopa is also okay to use. You can use intravenous hydralazine. But yeah, we generally, prefer labetalol. You can use that intravenously too, or nifedipine. That's a good combination. And yeah, and there's the guidelines on the hypertension that just came out this year, AHA, ACC guidelines on hypertension. The hypertension has been getting a fair amount of questions, these kind of questions on the general boards. So, if you screen for questions on hypertension in the Q bank, you'll find a lot of recent or else a lot of recent questions like this one. Well, this is different. 42-year-old female presents with pericardial diseases center with third recurrence of pericarditis within 18 months, compliant with high-dose ibuprofen and colchicine. Know that because that's the first-line therapy, the NSAIDs, high-dose NSAIDs and colchicine for 3 months. But she continues to have therapy. She has no contraindications to advanced therapy, but she's eager to avoid long-term corticosteroids, which is the following most appropriate next step according to 2025 guidelines on pericarditis. Low to moderate dose corticosteroids, colchicine, IL-1 blocking therapy with rilonacept or anakinra, refer for pericardiectomy, lifelong NSAIDs.
Lots of votes for C.
Yeah, that's what it is. And rilonacept is the only one that's actually, it's the one that has the FDA indication for, so that's the one you'd choose. And this is the classic thing where it's recurrent pericarditis despite NSAIDs and colchicine. So yeah, that's an important thing to keep in mind.
We have quite a few requests for pacemaker ECGs. I know you just spent an hour on that with the fellows.
Yeah.
You may have some other high yield topics you want to cover, but wanted to relay that. And I think the nice feature that you're highlighting is you can go based off of topic now. You can search within the database and just give yourself a lot of high yield cases for Pacer.
Yeah, and we just added a whole flurry of pacemaker malfunction cases. What is this? It's a whole bunch of pathology here, but from the Pacer standpoint, what's going on?
Too much culture.
We've got some failure to capture, failure to sense votes.
Yeah, it's clearly both failure to capture and failure to sense. It's just, I think this was like sinus tachycardia, low voltage in both the limb leads and the precordial leads, and there's failure to capture, and there's not failure to sense because it's called sensing abnormality for board scoring. It can be oversensing or undersensing. In this case, it's undersensing. But there's these small, the P waves are hard to see, but it is sinus tachycardia. This is a sick person whose pacemaker wasn't working. Sinus tachycardia with low voltage in both, and these pacemaker failure instances. Okay, so here's a 72-year-old male with prior MI and permanent pacemaker presents with syncope.
Capture.
We've got an undersensing vote, some AIVR.
AIVR, failure to capture.
Yeah,
it's
a AV junctional rhythm or tachycardia. I mean, I think we said that because, I mean, that's hard to know. Junctional rhythm 57 with a wide QRS, morphology diagnostic of RBB and LAFB. I mean, I think that's what it was. It looks like RBB and LAFB. And so, so it's a junctional rhythm. And then there's, failure to sense and some failure to pace because it's far enough from the QRS. It should be capturing sometimes. It does capture here one time. And then this is, these last two beats are, what do we call those? I guess it's just back to the, it's just back to the junctional rhythm. And again, you can tell the rhythm strip there. Okay.
Sorry, quick question about this one. What is it supposed to be sensing if there's an underlying junctional rhythm? Was it really failing to sense if there's nothing happening in the atria?
That's a good question, but I think this was probably a dual chamber pacemaker. Yeah, and still, and even so, you know, even if it's in the junctional rhythm, it's going to come down to the ventricle. So, you know, it should be sensing it in the ventricle, regardless. So it's failing to sense. So it's, you know, it's pacing right after a QRS. It should sense that QRS, whether it's coming from the atrium or the AV node or the ventricle. So here's an 89.
Do you mind speaking? Oh, sorry, Dr. O'Keefe. We've got a recurrent question that has been going on all hour. Do you mind commenting on junctional escape versus junctional rhythm and when to code which?
Yeah, you know, it's a really good point. And we junctional escape complexes usually show up like when there's another rhythm that's not like complete heart block or, you know, AIVR or yeah, so it's not AIVR, but when there's, you know, there's a pause, things like that, then we talk about a junctional rhythm, whereas a for a AV a standard junctional rhythm, it's usually it's the only thing you see, and lots of times it's faster. You know, it could be a junctional tachycardia or an accelerated junctional rhythm above 60 beats per minute. But it can just be a junctional rhythm too. That, you know, but there's no other, you know, there's no other sort of like other rhythm that's gone away that now this is escaping from. It is tricky though. All right, this is an 89-year-old male admitted for dyspnea and reduced stamina.
Lots of votes for failure to capture.
Yeah, should be capturing there and there, and it does capture there a little bit. And then anything else?
Some sensing issues as well.
Right cut. Safety. Look at that. Wow.
There's P waves here, right? And it's tracking the P waves. It's sensing the P and then sensing the ventricle. It captured there, but it didn't there. So what else is going on besides this pacemaker malfunction?
Complete heart block.
Yeah, it's complete heart block, right?
Complete block.
And then you could also code AV dissociation here, because, you know, the ventricles, like you know, there should be a QRS here, and it's not there. And so yeah, yeah, there's just really no underlying rhythm there. It's pretty slow.
Okay.
So yeah, third degree heart block, pacemaker malfunction, failure to capture sinus rhythm.
There was a question about Mobitz, and I see that that's on the score sheet as well. How do you differentiate between that and complete heart block in this situation?
Yeah, you know, we probably should take that off there. I mean, because, I mean, so you know, it conducts here, but that's because it's paced, you know. So I think the Mobitz 2 is actually not accurate here, because usually I have to see a P wave without a QRS, and then a P wave that does conduct. So I think the Mobitz 2 is not the right answer here. Oh, I guess we just said Mobitz 2 is because you don't know for sure. I mean, it could be Mobitz 2 or it could be complete heart block, because you only see one drop at a time, you know. But I guess I would probably vote for complete heart block. You just need to know, you see a longer rhythm strip to know for sure.
And not necessarily on this ECG, but there are questions about differentiating Mobitz 2 and AV block with 2 to 1. They would have to kind of give you clues to be able to differentiate between the two, correct?
Right. And we have some really good cases of that in here. So this is a good example of something you might see, like what we were talking about. What do you think here? We have lots of good
We've got to
examples.
vote for flutter.
Yeah, it's atrial flutter that then converts over to a sinus, right? And you know, one thing about flutter is like if you see like one P, you can count how many P waves are in between the QRSs, and if you just see whatever that is, and then subtract one, so it's like, and the heart rate's about 250, I mean 150 beats a minute. So this is, you know, probably 2-to-1 AV block in the setting of atrial flutter. And there is some sinus arrhythmia here too. If the R to R interval varies by more than 10% or 160 milliseconds, then you'd call sinus arrhythmia. But yeah, this is atrial flutter, sinus arrhythmia, 2-to-1 AV block, low voltage in the precordial leads, but the limb leads here it's above 5, so you wouldn't code that. All right, we probably should wrap up. It's getting kind of late. Sorry for the late start. I guess we could do, let's see. Any other requests?
Oh, we've got a lot of requests, Dr. O'Keefe. Some recent requests, tricky SVTs versus flutter, maybe some atrial tach.
Mm-hmm.
And then there is a question about echo scoring. So when we see something like a stress cardiomyopathy or Takotsubo, is that the primary diagnosis that we're supposed to code? Or are we also supposed to code the wall motion abnormalities such as akinesis or hypokinesis?
You know, so that's the thing. Let's just pull up a Takotsubo. We have a few Takotsubo here in the echoes, and that does show up. You know, you can expect to see that. So this is a classic Takotsubo looking, you know, octopus trap. So you wouldn't call global hypokinesis, you'd call regional, you know, you'd call regional wall motion abnormalities, but that's kind of tricky to know exactly what all to score, but there's a little bit of MR here. And look at the right ventricle is kind of abnormal too. It's like, you know, distally, the right ventricle is not moving that well. So you score abnormal wall motion, and you definitely would score under cardiomyopathies, Takotsubo, stress-induced cardiomyopathy, and then there's some mild mitral regurgitation here. But let's see if we have some more examples. Yeah, when you see a global hypokinesis, you know, you don't need to score all the wall motion, just the global hypokinesis option.
And then for a normal LV, people are observing that maybe coding normal LV size doesn't get you as many points, but is it pretty consistently important to score normal LVEF?
Yeah, that's what we generally tell people to score the LV systolic function if you can adequately see it. You know, it's so yeah, the size. I mean, sometimes you can score it, but definitely the LVEF and the options on that are the ejection fraction. Let's just take a random one here. Ejection fraction. Normal is above above or equal to 50%, 35 to 50, or less than 35. It's kind of, some people say severe, less than 30, but this is the board designation. So, and then you can code the abnormal, region wall, or global, and then here's the specific hypokinesis, akinesis, that kind of thing. And, I mean, that's a really important thing to take away here, is that do a bunch of these angiograms and echoes and ECGs as much as anything. And sometimes you might disagree with the answers, and that's fine. And, put and give us feedback down there. But you need to get familiar with what's on the score sheet, how it's located, how to kind of navigate it, because that goes a long ways on day 2. If you're familiar with the score sheet, and, we try to put diagnoses in the echo and angiogram that have been high yield recently. So I think that it's just important, especially now. It's kind of only a week till the boards. Just hit this high yield studying like this kind of stuff. And the first day, the Q bank has over 400 cases in it, and those are also kind of selected for specific reasons, and that's all day 1 is these multiple choice questions, and they'll usually show you some images or ECG or something, but yeah, we've tried to really focus on stuff that gets tested on. So what do you think, Caitlin? Can we wrap it up? It's been about an hour. And then
Sounds like we
again,
have a
I really
question coming through.
apologize for our late start. That was just some technical glitches.
One last question. Dr. O'Keefe, before you go, can you please clarify left anterior fascicular block and LVH? Do we code both together, or when do we code? Before you go, I think that would be a great help.
I think most of the time, if you see 11 millimeters or more of voltage in AVL, that's LVH. In the pressing of left anterior fascicular block, it's kind of controversial whether you should call it or not. I kind of doubt they're going to give you that kind of a controversy. But if you see, I would just look for criteria other place. Look at the QRS size in the precordial leads and see if it makes it for the Cornell criteria or the Sokolov criteria. And then look for, other changes that the other non-voltage criteria for LVH, like left atrial abnormality, left axis deviation. Of course, that would go along with LAFB, STT changes suggesting of, hypertrophy. So lots of times it'll be a constellation of things that go along with the LVH.
And I know you won't advertise this, so I will ask for everyone. One, you're getting great feedback in the chat about the new revamped website. What's the best way to access it? And does your old login work for the new website?
Yeah, the old login works. You just have to go to the new site, which is a real simple login. It's just CV Board Review, cvboardreview.com. And then you can go in there and it just says sign in, and then you have to reset your password. You can use the same password, but you just have to reset it there. And yeah, we've got, it's like a quantum leap forward because we have a lot of new cases, but I think things like the filtering and the search by keyword, and then also the chat box, it just makes it a lot more interactive and fun. And I just think, it's one of my, most favorite professional passions. And we'll continue. I apologize. There's some errors in coding and whatnot there, but it's almost kind of good, and we're correcting day to day. But I think it's kind of good because it forces you, when you're doing the cases, to think it through and to discuss it and discuss the nuance and the details. So I think it's a great place to interact with your peers about these important potential board questions and the score sheets.
Thank you so much. We really appreciate everything you do. Thank you so much.
No, thanks. It's my pleasure. I really appreciate your guys' efforts. I know you work very hard, and also appreciate you spending some of your valuable time with me tonight. And good luck on the boards. I know you'll do well.
Thanks, Dr. O'Keefe. You're the best.
Thanks, everybody.
Thank you.